What is going on, wonderful people? This is Medicosis Perfectionalis, where medicine makes perfect sense. Today we'll talk about the topic of neonatal immune-mediated thrombocytopenia. What does penia mean? Few, low number. Cyto, cell. Thrombocyte are the cells of the thrombus, aka the platelets. In other words, thrombocytopenia means decreased number of platelets. This can happen in a neonate for a variety of reasons. One of them is immune-mediated. We have antibodies from the mother leaving the mother's blood and going to the baby to destroy the baby's platelets. When the baby's platelets are attacked, the baby can get these purple spots all over his body. The small ones are called petechiae, medium ones are called purpura, the big ones are called ecchymoses. This video was made possible thanks to the generous donation of Mikkel. Thank you so much, sir, for supporting my channel. I'm honored. And please, guys, if you're watching this video, take 3 seconds to say thank you to this great gentleman in the comment section. Thrombocytopenia is a problem with blood cells. So let's talk about blood. Okay, blood is made of plasma and cells. The cells are red blood cells, white blood cells, or platelets. Today's topic is a problem with the platelets. Where do the platelets come from? They came from their grandmother, the megakaryocyte, big grandma. Each megakaryocyte can give you 1,000 platelets. That's a big grandma. Where do the megakaryocytes come from? From the bone marrow. So let's talk about platelets, also known as the thrombocytes. These are biconvex pieces of the megakaryocyte. They are not actual cells, they are pieces of their grandmother. When the grandmother, the megakaryocyte, exploded, it gave us 1,000 platelets. Each platelet is taking a piece of the cell membrane and a piece of the cytoplasm from the megakaryocyte. What stimulates platelet production? TPO, or thrombopoietin. Where does it come from? From the liver. The liver makes this protein, which is TPO. TPO goes to the bone marrow and tells the bone marrow to make more platelets. And that's why one of the causes of low platelets is liver disease. What's the function of the platelet? The platelet is like an engineer. How does the engineer know if this building was affected by earthquake or not? Easy. The engineer looks at the wall. If the paint is smooth like this, probably the earthquake did not affect the building. But if the paint is destroyed and the underlying layer is exposed, that's a problem. This has been probably affected by the earthquake. The platelet does the exact same thing. The platelet cruises through your blood vessel. If your blood vessel lining is smooth and clean like this, everything is hunky-dory. But if the endothelium is injured, because I cut myself, for example, then the subendothelium is exposed like this, and the platelets will get mad, and they will start calling their friends, aggregate together, they will form a clot to stop the bleeding. I injure myself. After I injure myself, my vessel will clamp to decrease blood loss. Then the platelets will come. The story of the platelets is called primary hemostasis. After this, coagulation factors will come. We call this secondary hemostasis. Now, congratulations, you have a clot. This will decrease blood loss. These are the steps of making the clot. Step number 1, constrict the vessel, clamp it down, narrow the lumen to decrease blood loss. Step number 2, get the platelets. We call this primary hemostasis. Step number 3, get the coagulation factors. We call this secondary hemostasis. All of this is normal. I injured myself. Step number 1, constrict the vessel, make it narrower. Step number 2, get the platelets. When the platelet sees that the endothelium has been broken like this, endothelium, they get crazy. They will attach to the subendothelial collagen. They will call on the other platelets and they will aggregate together, and then they will call on the secondary hemostasis, which is the coagulation factors. How about secondary hemostasis? Secondary hemostasis is the story of the coagulation factors or the clotting factors. Who makes them? The liver does. We're trying to convert fibrinogen to fibrin. These are strong fibers and they will trap your red blood cells, forming a clot, stopping the bleed. These are your coagulation factors. Each one has a name and a number, but that's not today's topic. So let's review. How do we stop bleeding? You have to vasoconstrict, then the platelet story, then the coagulation factor story. Okay, The platelet story is known as primary hemostasis. Coagulation factors known as secondary hemostasis. All right, let's say that I have a disease. I have a problem in primary hemostasis. How will I know? We ordered 2 lab tests. The first one is the platelet count. Let's count them. And the second one is the bleeding time. Let's see their function. Let's take a look at their number. Let's take a look at their function. What if I have problems with secondary hemostasis? We will check you via PT and PTT tests. Primary hemostasis, it's the platelet story. Secondary hemostasis, the coagulation factors. What's the end result? Make a platelet plug to decrease blood loss. What's the end result here? Make fibrin. How do we test for primary hemostasis in the lab? Platelet count, bleeding time. Secondary hemostasis, PT and PTT. If I have a disease in primary hemostasis, I get superficial bleeding in my skin. But if I have problems with coagulation factors, I get a deeper bleeding deep down in my joints, in my muscles, in my gut, etc. Today's topic is neonatal thrombocytopenia. Do you think it's a problem with the platelets or with the coagulation factors? It's a problem with the platelets. We call this primary hemostasis defect. Okay, the next question is it a problem with platelet number or a problem with the platelet function? It's a problem with platelet number. We have decreased number of platelets. We call this thrombocytopenia. Thrombo, platelet, cyto, cell, penia, few. Anytime I have a problem in my platelet, we have 2 possibilities. Problem with platelet number, problem with platelet function, or both. We test for the number via platelet count. We test for the function via bleeding time. We have established that neonatal thrombocytopenia is a primary hemostasis problem. Is it a problem with the platelet or the vessel, the platelet? Is it a problem with platelet number or platelet function? It's a problem with platelet number. We have decreased platelet number. Is it truly a disease or is it a pseudo thing? It's truly a disease. So let's talk about the normal platelet number or platelet count. Normally, it should be between 150,000 to 400,000 per microliter. So you can write it this way. Let's say I have 200,000 platelets per microliter. Some labs will write it this way. Other labs will write it this way. 200 times 10 power 9 liter. Because as you know, 1 liter has a million microliters. If you want to convert a million into a billion, you should remove 3 zeros, like this. Anyway, I prefer this one, 150 to 400,000 per microliter. Okay, it follows a bell-shaped curve like this. Most people are here. Most people are normal. They have this kind of range. Here is a problem with many doctors. Some doctors will say, "Oh my goodness, my patient's platelets are 145,000. My patient is gonna bleed to death." Shut up. This is a doofus who neither understands math nor medicine. Look here, my friend. You have to understand that there is normal variation between people. 150,000 might be normal for someone. 140,000 might be perfectly fine for another person. There is variation. Clinically, you should care about thrombocytopenia when the platelet count drops below 50,000. That's getting serious. How about a platelet count of 90,000? You're getting like borderline here. Let's say that I came to you, all right, and my blood pressure was high. What should you do? "Oh, I should start you on diuretics." Wrong. You should repeat the test 3 times before you even diagnose me as hypertensive. But your blood pressure was high today. It could be a normal variation. So theoretically, thrombocytopenia is platelet count less than 150,000. Clinically, however, it's a totally different story. If your platelet drops below 90,000, the bleeding time will start to prolong. This is the test for platelet function. Of course, if you have fewer platelets, they will not function as well as numerous platelets. Less than 50,000, you will start to see symptoms and signs such as petechia purpura ecchymosis. Remember those purple spots on the baby's skin? You can also see some bleeding in the gums, etc. Less than 30,000, you will start to bruise without even being hit. Nobody hit you, but you have bruises. Less than 20,000, there is risk of severe bleeding. Less than 10,000, you need platelets right now. Less than 5,000, you are vulnerable to extreme severe bleeding. In other words, thrombocytopenia should not be managed categorically. It should be managed incrementally based on how severe it is. Do not just look at the number, oh, the platelet count is less than 150,000, therefore I have to do something. Calm down. When I have fewer platelets than normal, it's called thrombocytopenia. More platelets than usual, it's called thrombocytosis or thrombocythemia. We're talking about thrombocytopenia today. Now here's the question, is it true or is it false? How do I know? First, let me tell you this story. Pseudo is not a disease. This is a problem with the lab. The lab made a mistake. They diagnosed the patient with thrombocytopenia, but the patient was perfectly fine. It's a lab problem. True thrombocytopenia is an actual disease. You should see a doctor for this. No one should see a doctor for pseudo. How do I know if it's pseudo or true? The easiest way is to repeat the test. If the platelet count was low in the first test, but perfectly normal in the second test, like let's say in my first test, my platelet count was 40,000. In the second test, it was 250,000. You can bet the rent money. It was pseudo. Why does pseudo thrombocytopenia happen? It's a lab problem. They collected your blood in a purple top tube. What's the problem? This purple tube has EDTA. Why do they add EDTA to the tube? It decreases calcium and prevents clotting because we want your blood to remain in the liquid form when it goes to the lab. We don't want your blood to clot in the tube because we will not be able to run any tests on that blood. However, EDTA can cause a problem in certain circumstances. EDTA will cause antibodies, and the antibodies on the platelets like this, they will form rosettes like this. The stupid machine, the stupid computer, will count these 8 platelets as 1 platelet. So let's say that your actual real platelet count was about 300,000 per microliter. The stupid machine in the lab will count each 8 platelets as 1. So it will give you 300,000 over 8, or about 38,000 platelets. 300,000 is normal. 38,000 is thrombocytopenia. But it's pseudo. It's an artifact. It's not true. It's a lab mistake. That's why we call it the analyzer, because it's a stupid butt machine. How do I prevent this problem? Okay, we will repeat the test again, but we will use a different test tube, like green tube, blue tube, any tube that does not contain EDTA. Or we can take the same sample and look under the microscope, peripheral smear. If you see the platelets clumping like this, you know that this number was caused by rosette formation, which is pseudo. This patient is not a patient. He's normal. So your platelet count could be normal, they could be low, they could be high. If they are low, thrombocytopenia, it could be pseudo, purple tube, stupid butt machine, or it could be true. What's the cause of pseudo? A lab defect. What's the cause of true? All kinds of causes. You have low platelet number, maybe because you're not making enough platelets. Or maybe you are making them, but you're destroying them quickly. Overdestruction. Or maybe you're making them fine. You're not destroying them, but your spleen is swallowing all of your platelets because you have a huge spleen. And as you know, platelets love to hide inside the spleen. Underproduction. Why is the patient not making enough platelets? Maybe there is aplastic anemia, which is a wrong name. The correct name is aplastic pancytopenia. The bone marrow cannot make red blood cells, cannot make white blood cells, cannot make platelets. Poor marrow. Myelodysplastic syndrome, very similar. Liver disease, because when I have liver disease, I don't have TPO, I don't have anything to boost my platelet production, I will have low platelet count. Maybe I'm dehydrated, maybe problems with B12 and folate, Fanconi anemia, or Bernard-Soulier. Today's topic, neonatal immune-mediated thrombocytopenia, is caused by platelet overdestruction. So why would we see true thrombocytopenia in children? Underproduction, overdestruction, or splenic sequestration. The spleen is swallowing them. The underproduction could be congenital diseases or acquired diseases. The overdestruction could be medications, could be other disease such as HUS, giant hemangioma, because also the hemangioma acts as if it's a spleen. It swallows lots of platelets. DIC, or immune-mediated. This is today's topic. Today we're talking about 2 diseases. One is called neonatal passive autoimmune thrombocytopenia. The other is called neonatal isoimmune thrombocytopenia. I will tell you the difference shortly. But please understand that neonatal immune thrombocytopenia is not the same as ITP or immune thrombocytopenic purpura. These 2 diseases are in one land, ITP is in another land. Yes, they are similar, but they are not the same. This is more likely to happen in a fetus or a neonate, just before birth or just after birth. ITP can happen in young children, not necessarily after birth, let's say 2-year-old, 3-year-old, 7-year-old, or it can happen to old people, 20, 30, 50. This disease is caused by antibodies from the mother, crossing the placenta, going from the mother to the baby, destroying the baby's platelet. ITP is triggered by usually a viral infection. No one knows why, but this viral infection for some reason or another triggered a response of antibodies attacking the platelets. But these are not my mother's antibodies, these are my own antibodies. Big difference. Okay, I am a patient with low platelet number, thrombocytopenia. What are the symptoms? Many patients have no symptoms whatsoever. Some patients have superficial symptoms, superficial bleeding. What's the superficial? Skin and mucous membrane. These are superficial structures. If it's a skin problem, you have these purple dots. The small ones are called petechiae. Medium ones, purpura. Big ones, ecchymoses. Mucous membrane, I can have nose bleed. I can have easy bruising. I can have abnormal menses, lots of blood in menstruation. Maybe my gums are bleeding. Maybe I am coughing up blood. Maybe I have blood in the urine. In severe cases, I can have bleeding in my brain. But there is no deep bleeding because deep bleeding happen when I have a problem, not with the platelets, but with the coagulation factors. Secondary hemostasis, baby. And that's why patients with thrombocytopenia, if it's just a problem with the platelet, they will not have lateral bleeding. They do not have bleeding into joints. They do not have bleeding into muscles. These are deep structures. Thrombocytopenia can only cause superficial symptoms most of the time. Let's have some clinical points here. Remember, thrombocytopenia theoretically is not the same as clinically. Theoretically, anything less than 150,000. But doctors start to care and pay attention when your platelets are around 50,000 or less. If I have low platelets, I have superficial bleeding, such as petechia, purpura, ecchymoses, bleeding gum, bleeding nose, etc. You are more vulnerable to get bruising from thrombocytopenia if you also have vitamin C deficiency, known as scurvy, because both diseases love to cause bruising. Thrombocytopenia destroys your platelet. Scurvy destroys your blood vessel, because normally you need platelets and blood vessels in order to make a clot and stop the bleed. If I have antibodies destroying my platelets and antibodies destroying my red blood cells in the same time, we call this Evans syndrome. During pregnancy, the mother is vulnerable to thrombocytopenia. Why? There is something called benign gestational thrombocytopenia. It's not a big deal. Or it could be a disease such as ITP, TTP, preeclampsia, DSC. Those are a big deal. A patient came to me. The patient does not have any symptoms, but I ordered some labs and discovered that the platelet count is low. What's the next step? There is the real life answer and there is the textbook answer. In the real life, just repeat it. Repeat the platelet count, because this could be pseudo. The easiest way to know if it's pseudo or true is to repeat it. The easiest way to distinguish between just some random variation and an actual disease is to repeat the platelet count. It's a very cheap test. Go ahead and repeat it. But if you are a student and they are asking you on your exam, you have to follow this algorithm. What's the algorithm? The algorithm goes like this. A patient has platelet count less than 150,000. What should I do? Now you gotta pay attention, because is this a problem with the platelets alone, or does this patient have a problem with the platelets, red blood cells, and white blood cells? What if my patient has problems with all of the blood cells? Oh, this means the bone marrow is destroyed, and therefore we will need to examine the bone marrow. Usually we will do a biopsy, but again, in real life, we should repeat this twice before you biopsy someone's marrow. That's an invasive procedure. Okay, medicosis, only the platelets are the problem. Red blood cells, white blood cells are fine. What should I do? Look in the peripheral smear. If you see the clumping, the satellite, you know that this is pseudo. This is a lab problem, the stupid butt machine. So just repeat the test in a different tube. What if I saw schistocytes? This could be DIC, TTP, HUS, help me. What if the platelet count is low, red blood cell are normal, platelet are normal, or big platelets? This could be ITP, drug-induced thrombocytopenia, or infection-induced thrombocytopenia. What kind of infections? Could be viral, could be HIV, which is a virus, could be infectious mononucleosis, and many others. What's the difference between the neonatal immune-mediated thrombocytopenia, where the mother's antibodies are attacking the baby's platelets, and a baby who is born with a lazy bone marrow that doesn't work? Here's a big difference. Neonatal immune thrombocytopenia is a problem with the platelets only. Red blood cells are fine, white blood cells are fine. But aplastic anemia is a pancytopenia. That's why I don't want to call it aplastic anemia. I prefer to call it aplastic pancytopenia. Here everything is low. Red blood cells, low. Platelets, low. White blood cells, low. If you look in the bone marrow has normal cellularity. But in aplastic anemia, the lazy bone marrow is hypocellular. You will not find any cells. This bone marrow has been destroyed. All of this was a necessary introduction. Now, let's get into today's topic, neonatal immune-mediated thrombocytopenia. Antibodies from the mother crossing the placenta, destroying the baby's platelets. Neonatal immune-mediated thrombocytopenia has two subtypes, passive autoimmune thrombocytopenia and isoimmune thrombocytopenia. What's the difference? Here is the difference. In passive autoimmune thrombocytopenia, the mother was already sick. Sick with what? With immune thrombocytopenic purpura. Mommy already had antibodies against her own platelets. Okay, so the mother had thrombocytopenia. The mother had antibodies against her own platelets. These antibodies left the mother's blood, crossed the placenta, went into the baby's blood, and attacked the baby's platelets. And now, even the baby will have thrombocytopenia. So in passive autoimmune thrombocytopenia, mommy had passive antibodies that were available before. They are historic. They are not intended to attack the baby, but they cross the placenta and attack the baby's platelets. On the other hand, in isoimmune thrombocytopenia, the baby's platelets carried an unknown antigen, an antigen that the mother has never seen. But hey, medicosis, this is the mother's own baby in her womb. Where did the baby get the unknown antigen from? From the father. Oh, I get it. This unknown antigen came from the father. The unknown antigen is on the baby's red blood cell. This unknown antigen is going to cross the placenta from the baby's blood to the mother's blood. And now, mommy has never seen this antigen before. Danger, danger, we have been invaded by an outsider. Let's attack it. Let's develop brand new antibodies against those antigens. Not pre-existing antibodies, nope, brand new antibodies against the antigen. We'll destroy the antigen. We'll cross the placenta. Oh, I saw the antigen again. I will destroy it again. And now the baby's platelets will be destroyed. The mother had normal platelet count. Mother's platelets were fine. Mommy did not have thrombocytopenia. However, the baby has thrombocytopenia. That's the difference between passive and isoimmune. Let's do it again. Passive autoimmune thrombocytopenia. Mommy had ITP. Mommy had pre-existent antibodies against her own platelets. These antibodies left her blood, crossed the placenta, went to the baby's blood, destroyed the baby's platelets. Now both of them have thrombocytopenia. How about isoimmune thrombocytopenia? The mother is fine. The mother has normal platelets. But the mother was triggered by an unknown antigen on the baby's platelet that the baby had acquired from his father. The antigens cross the placenta. Now they are in the mother's blood. They trigger her immune response. Mom will form brand new antibodies against the antigen. These antibodies will cross the mother's placenta. They will attack the baby's platelets. And now the baby has thrombocytopenia, but the mother has normal platelets. Do you know this disease is similar to what? Do you remember Rh incompatibility? Yeah, mommy was Rh negative. The baby was Rh positive. The baby's antigen triggered the mother, and now mommy's gonna make antibodies to attack the baby. However, there is a big difference. Rh incompatibility spared the first pregnancy. The first newborn will be fine. However, the second pregnancy, the second baby, will be destroyed. But here, whether we're talking about passive or isoimmune, in both cases, the first pregnancy can be affected. Even the first pregnancy is vulnerable. The first pregnancy is vulnerable, the second is vulnerable, the third might even be more vulnerable, etc. Let's do it again. The mother has antibodies, cross the placenta, attack the baby's platelets. Alright, when you have antibody against the platelet like this, who's gonna attack this complex? The macrophage of the baby. Where does this happen? In the spleen of the baby. Spleen or any of the reticuloendothelial organs. Spleen, liver, nodes, etc. Why did the baby's macrophage attack the baby's own platelets? Because this looks weird. Platelets should not have antibodies hanging on top of them. So this is abnormal. The baby is cleaning house, so the baby cleaned his own platelets. But the antibodies came from the mother. What's the incidence of neonatal immune-mediated thrombocytopenia? 1 in every 5,000 live births. Let's talk about symptoms. Do you think we'll have superficial bleeding or deep bleeding? Superficial bleeding. Petechia, purpura, ecchymosis, especially petechia and purpura. Are they localized or are they all over the baby's body? All over the body, because this is not a localized disease. This is a generalized disease. We have platelets in every part of our body because they are floating in the bloodstream. So the baby will be born with generalized petechia and purpura. The symptoms appear within the first few days after delivery. In certain cases, the disease can be severe, causing intracranial hemorrhage, bleeding inside the baby's skull or brain. And this is more likely to happen during vaginal childbirth, normal labor, because the baby's head is getting squeezed inside the mother's birth canal while coming out of the mother's womb. And this squeezing presses on the baby's skull. So now we have two forces in action. Number one, the pressure on the baby's skull. Number two, the thrombocytopenia. And that's why if we know that the baby has neonatal immune-mediated thrombocytopenia, we should deliver the baby via cesarean section and not by normal delivery, in order to protect the baby's head from getting squeezed into oblivion. Many diseases have palpable purpura, other diseases have non-palpable purpura. Basically, close your eyes and put your hand on the patient's arm that has the purple spots. After closing your eyes, can you feel it? Then it's palpable. I can't feel it. I can't feel anything. I can just see the purple color, but when I close my eyes, I don't feel anything. This is non-palpable. Today's kid with immune-mediated thrombocytopenia has non-palpable purpura. Some purpura is palpable, others are non-palpable, but all purpura are non-blanchable, which means look at the baby's arm. Press on one of these purple spots. Did they disappear? The answer is always no. Purpura does not disappear when you press on it, in every case. What if it disappeared? Then it was not petechia or purpura. It was probably an allergy, like bee stings, anaphylaxis, allergic reaction, etc. But it was not petechia or purpura. Purpura should not blanch on pressure. How do I diagnose a baby with neonatal immune-mediated thrombocytopenia? Take a blood sample and order some labs. How do I take blood sample? Well, are you talking about a fetus or are you talking about a neonate? If you're talking about a fetus, we have fetal scalp sampling or we have percutaneous umbilical cord sampling techniques. Get a blood sample from the baby. After birth, it's easy. Get any vein and take a blood sample. If the umbilical cord is still available, you can take a sample from the umbilical cord because this is the baby's blood. Alright, I got my blood. What should I do? Order some labs, such as what? Platelet count, to test for the platelet number. In this disease, we'll see decreased platelet count. How about bleeding time? Bleeding time is for platelet function. But since we have low platelet number, few platelets cannot undertake the function of normal platelets, so you'll have prolonged bleeding time. The platelet count is abnormal and therefore bleeding time is prolonged. This baby takes longer for his blood to clot. How about PT and PTT? They are absolutely normal. Why? Because we have no problems with the coagulation factors. The secondary hemostasis is fine. Why did this disease happen? Antibodies from the mother and antigens from the baby. Can we detect them? Yes, we can detect them via certain techniques. The most common antigen is HPA1A. Why do we call him allo? Alright, in medicine there are many words, including allo and auto. Alright, If we are talking about my own antibodies attacking my own cells, we call this auto, because auto means self. That's why you have an automatic transmission in your car, because it's self shifts. How about allo? Allo is like, when you call your friend on the phone, what's the first word that you say? Hello. So I remember hello. Hello is talking to a friend, not talking to yourself, talking to a friend. So where did we get the antibodies from? From a friend, from the mother. Oh, that's allo antibody and allo antigen. How do we treat neonatal immune-mediated thrombocytopenia? Before delivery, give intravenous immunoglobulin to the mother, especially during the second and third trimester. Why IVIG? IVIG inhibits macrophages and it inhibits platelet destruction. So now the mother's antibodies will not attack the baby's platelets. All right, during delivery, please try to deliver via cesarean section, not through vaginal delivery, in order not to squeeze the baby's head in order to reduce the incidence of intracranial hemorrhage. After delivery, no symptoms, no treatment. No severe thrombocytopenia, no treatment. Let's say the baby's platelets are 140,000. Yes, theoretically they are low, but it's not too bad. Do not do anything, just watch and wait. But if it's so severe, what should I do? You can try IVIG. It inhibits macrophages, preventing platelet destruction. You can give steroids. Why? Steroids are immunosuppressants, and this disease is immune-mediated. I give medication to suppress the immunity, to suppress the antigen-antibody complex formation and attack. Then we'll give IVG to the baby. If the mother was Rh negative, the baby is Rh positive, mom needs anti-D immunoglobulin. If the disease is so bad and the symptoms are so severe, you can transfuse platelets. Make sure that these platelets share the maternal alloantigen. We call this washed maternal platelets because these are the antigens that we are used to in this specific patient. If all of this fails, you can try to boost platelet production via a thrombobag and romiplastim. Have you noticed thrombobag? Because it boosts thrombocytes, and romiplastim, platelets. Rituximab is similar to steroids. It's an immune suppressant to suppress the immunity. But of course, everything has side effects. Immunosuppressants, yes, they will decrease the severity of this disease, but when you suppress your immunity, you become more vulnerable to infections. There are no solutions in life. There are only trade-offs. What if the disease is not improving and it's so severe? Well, since the platelets are hiding in the spleen and the platelets are being destroyed by the macrophages in the spleen, it's time to remove the spleen, but this is last resort. You only remove the spleen when everything fails and the disease is so bad. I've good news for you. Most babies with neonatal immune-mediated thrombocytopenia are gonna resolve and be fine on their own in about 2 to 4 months after delivery. But be careful, your job is to pay attention in the perinatal period, especially around delivery, because we do not want to squeeze the baby's head too hard. We want to prevent intracranial hypertension as much as we can. Make sure to tell the parents that if this happened in this pregnancy, it can happen again with subsequent pregnancies. Let's have some Socratic dialogue. Why do we give steroids? Immunosuppressants. Why rituximab? Immunosuppressant. Why do we give IVIG? It inhibits or satiates the macrophages so that they stop attacking the baby's platelets. Why do we give anti-D immunoglobulin? Because it induces a mild hemolysis. Now these macrophages will get busy attacking the red blood cells, leaving my platelets alone until they can recover. You have just watched the discussion of neonatal passive autoimmune thrombocytopenia and neonatal isoimmune thrombocytopenia, which are not the same as ITP. Let's review ITP real quick. This will be a very quick review. If you want the original discussion, I have a video called ITP on my bleeding and coagulation playlist here on YouTube. You can call it immune thrombocytopenic purpura, or you can call it immune thrombocytopenia. What's the problem? My own antibodies attacking my own platelets. Which part of the platelet is being attacked? Usually GP2B3A protein. This green thing right here. Sometimes this is getting attacked, but most of the time the GP2B3A is the protein getting attacked by my own antibodies. This GP2B3A receptor is very important because it's involved in many diseases, including immune thrombocytopenic purpura, where my own antibodies, autoantibodies, because these are my antibodies, not my mother's, these are my own antibodies attacking my own platelets. Is ITP a defect in primary hemostasis or secondary hemostasis? Primary. Is the platelet count low, normal, or high in the disease? Low. That's why it's called immune thrombocytopenia. Is it pseudo or true? Of course it's true. It's right here. So in ITP, I know that the platelet count is low. But how about the platelet function? It's also destroyed. Because when you attack the GP2B3A of the platelets will not be able to aggregate and gather together to stop the bleeding. So in ITP, I have a problem here and I have a problem here. Why do I have problems with platelet function? Because the nasty antibodies, these are my own antibodies, are attacking my own platelets, specifically in the GP2B3A protein. And when my own antibodies attack this protein, the platelets will not be able to gather together to stop the bleeding. Therefore, what will be the symptoms? Bleeding. This receptor is very important. We have talked about it before. It's involved in many diseases, including ITP. ITP is a problem with platelet number and with platelet function. What are the symptoms? Many patients are asymptomatic. Some of them have superficial bleeding, such as skin problems, petechiae purpura ecchymosis, or mucosal bleeding. In today's story, ITP could happen to the mother first, and then the mother's antibody could attack the baby's platelets, or this can happen to a child after birth. Everything about ITP was discussed before in my video on ITP. Pause and review. Notice that the management is very similar. Acute ITP usually happens to young people. Chronic ITP, they are usually old. They have had this disease for a very long time. Acute ITP goes away on its own. Amazing. Chronic ITP, it will linger. And this can happen to a pregnant mother, and it will linger until the antibodies attack the baby's platelets. And now we have a mother with ITP and a baby with neonatal immune-mediated thrombocytopenia. When everything fails, we remove the spleen, but this has to be last resort. The spleen is an important immune function. If you decide to remove it, the patient will be vulnerable to many infections. Make sure to vaccinate before you remove it and antibiotics after you remove the spleen. Why would we remove the spleen? 3 birds with 1 stone. Because the platelets are hiding in the spleen. When you remove the spleen, the platelets will go out to the circulation, raising your platelet count, relieving your symptoms. Moreover, where are these autoantibodies getting formed and synthesized? In the spleen. So when you remove the spleen, you remove the factory that makes the antibodies. Also, where are the platelets getting attacked and destroyed? In the spleen. So when you remove the spleen, no more war. Don't forget, all purpura, all petechiae, all ecchymoses are non-blanchable. When you press on them, they do not disappear. ITP is a diagnosis of exclusion. Please remember, we're trying to treat the patient. We're not treating the lab results. I don't care that the platelet count is slightly low. If the patient is fine, leave the patient alone. By the way, I have 2 entire playlists on hematology and bleeding and coagulation respectively on this YouTube channel. Today's topic was about neonatal immune-mediated thrombocytopenia. Here is everything you need to know in one slide. Pause and review. And here is ITP. Pause and review. And here is a very good chart for primary hemostasis disorders when I have problems with my platelets. If you like this video, you will love my cardiac pharmacology course on my website, medicosisperfectionalis.com. It has 50 videos with notes and cases. I also have a kidney physiology course, and you can get a 40% discount towards any course on my website. Just use discount code KIDNEY at checkout, available for a limited time only. Please take 3 seconds to say thank you to Mikhail. Thank you, good sir. If you like this video, please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my premium courses. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense. Peace.